we're out and about.
Is
she in your shot? No, I'm making sure that she is.
Yeah, I think I saw you doing something from your apartment the other day.
Yes, I know. And I was like,
that all felt weird, right?
Apartment.
Right, yeah.
This is my apartment's debut. Luckily, I have a great wall.
Yeah, that was pretty good.
It has a green screen, so I'll like bring in graphics and stuff. It doesn't look like we're desperate times. Yeah.
We ready?
If you could chit chat for us just a little to check your mic.
Okay. How's this? This is about my normal tone of voice. Is that going to be good enough? Clarissa, is that good enough for you? A little louder? You're using the mic off your phone?
Yes.
Okay. I'll be louder than that then. Is that good? If I speak about this level, is that good enough for you, Clarissa?
Should be good.
Okay.
1 second, we're waiting for the live to just pop up here.
Are you going live on air?
On the website.
On the website, okay. Is anyone else doing lives?
Yeah.
You're
Yeah,
live on the
Marty's
website too? Okay, and you're live too? Okay, perfect.
Huh?
Okay, they're talking to each other. Come on.
Morning.
Are we ready?
Yes.
Okay, Clarissa, you ready? Okay, good morning. I'm Russell Myers. I'm the CEO of Midland Health. And today we're beginning a daily update here in front of the hospital. We're going to be sharing some data, some statistics, some of which are widely available, some are specific to our local environment. We'll give you a few updates, things that have changed recently. I'll take questions from the press that are here, and I understand we may have some live questions from Facebook Live. So we'll get started. This will just take a few minutes. To begin with, statewide numbers, 334 cases of COVID-19 confirmed in the state of Texas. In Midland County, there's still only 1 and a total of 2 in the Permian Basin. Across Texas, there have been 6 deaths so far from COVID-19. There have been none in Midland or in the Permian Basin. Here at our hospital, activity levels are very low now as people stay home and are practicing social distancing and self-isolation. Our emergency department volumes over this past weekend were less than 100 patients each day. That's in the neighborhood of half our usual volume. So I think that's a good thing in general. We certainly want people to get the care that they need, but unnecessary visits are a good thing to avoid. Inside the hospital, we're at only 41% occupancy. That's pretty low for this time of year. We tend to trend down in the late spring and summer, but we're moving faster than usual in getting people out of the hospital, probably to a great extent because we have stopped doing elective procedures. Elective surgeries and endoscopy procedures were suspended last Monday. They will continue to be suspended at least through this week, and then we'll reevaluate. In our critical care environment, we have 12 patients today. We have cohorted 5 patients who we have some suspicion about possible respiratory disease into a separate area that can be segregated from the rest of CCU. We have a similarly segregated medical surgical unit, and there are 9 patients on that unit. Only one of those patients is a confirmed COVID-19 case. We have some suspicion. We're watching the others until their test results come back, which we expect to be at any time. Testing across the community, we're aware of 110 tests that have been done so far, and to date only 7 results have come back. We're anticipating lots of results coming early this week and looking forward to that. We are extremely concerned about the availability of personal protective equipment. You've all seen a good bit of information about that on the national media. It's a common problem across the country and really around the world. We are actively conserving personal protective equipment. We are soliciting donations. We have a site set up at the Legends Park office complex, which is at 5615 Deauville on the west side of town near the stadium complex. 10 a.m. to noon each day this week, we'll be accepting donations at that site. So if you have N95 masks, we'll be particularly pleased to get those. Any other kind of masks, face shields, those are particularly important as we accumulate personal protective equipment to protect our staff. Let's see. Visitation. We have severely limited visitation in the hospital. The entrance behind me is our emergency department. That is the only point of access for patients to come to the hospital. We are not accepting visitors with very rare exception. Certainly anyone who is sick will not be admitted. A parent with a child in pediatrics, a caregiver in labor and delivery, a family member who is visiting a patient who is at the end of life. Those are about the only exceptions we're making to allow patients to visit or visitors to come in. Otherwise, we are trying to be as safe as possible and limiting visitors severely. Let's see. We've had challenges with our phone system. As you know, for a while now, we've been encouraging people to call our 6-8 nurse telephone nurse triage hotline to get instructions, to get advice about their symptoms, to be informed about whether to come to the ER, to set up for testing, or whatever other actions people should take with regard to their symptoms. Those phone lines have been overwhelmed, and we have been working to add capacity. We would encourage people to continue to call 6-8 nurse if you believe that you have symptoms, if you have concern about your condition, and as today and tomorrow unfold, we'll have significantly greater phone capacity, so you'll be much more likely to get through on the first try. Let's see. Last thing that I want to say before we take questions is to remember the same things we've been telling people for several days now. Stay home, whether you have symptoms or not. This is the time when we have the opportunity to stop this virus, to slow its spread, but we're going to do so by staying home, by social distancing, by very careful hand hygiene, washing your hands for 20 seconds on a regular basis, trying not to touch your face, doing everything that we can to minimize the spread of the disease and to help our community avoid overwhelming our caregivers. We're in really good shape now. We're planning for the worst and continuing to talk about that every day, but it's really important that we take advantage of this opportunity to slow the spread of the disease. So let's all continue to do that. Stay home when you can. If you have to go out, practice social distancing, wash your hands. Thank you. Now, are there questions from anybody?
Yes. So, what are the extra steps the hospital is trying to make to be extra prepared for the unknown?
Well, preparing for the unknown is one of our biggest challenges. The first things that we're doing are using the space that we have. I mentioned in critical care, the way that the unit is divided, we have 36 beds on a long hallway and a separate 12 beds on a short hallway. You can see the building is in an L shape. We have cohorted patients in the short hallway on the critical care unit and one other floor. So that's one way that we're trying to get ahead of this. When we have patients who either are confirmed or are suspected, we move them to those areas so that they can be cared for by a single group of staff. We can control the personal protective equipment, make sure they have it available. So that's one thing. We have contingency plans to move to larger spaces where we can cohort bigger groups of patients if we need to. And we're beginning to talk about what happens in an absolute worst case where the hospital's facilities are not enough. We have some other options available to us where we could use other space in the community. We're a long way from that now with the hospital only at 40% capacity. One thing I meant to tell you earlier, we have lots of ventilators. With 9 patients on ventilators today, we have a total of 44 regular ventilators, and we have 37 more ventilators that are single use. We can use for one patient through the duration of their stay, and then they have to be disposed of because they can't be cleaned. So capacity is really substantial. We're nowhere near our capacity limits, so we've got a few days to plan for what the worst case might look like, and we're working on that now.
And the patient that has COVID-19, how is the patient doing at this time?
I don't have an update on that patient's condition. I'm sorry. He's still with us, still in critical care. That's about all I know at this point. Sorry. Sir.
What's being done to broaden testing capabilities?
Testing capabilities are interesting. We have seen steady growth in testing. As the commercial labs have come online, we've sent most of our testing to one of the commercial labs in the last few days. We're getting good information that there is a new round of FDA-approved testing that is being released this week. How soon we will get access to that testing, we don't know. The manufacturer who's making that available does provide testing for equipment that we actually have in-house. So we're hopeful that once those tests are released, we'll be able to do them ourselves, and that could significantly broaden the ability of our providers to test locally. We don't have details about that yet, but I'm going to be doing these updates every day, and I would imagine sometime this week I'll have a really good idea of not only how many we'll have, but how we'll make those available. I would imagine we'll still be looking for people to be meeting the protocol, certainly with signs and symptoms before we expand, but that remains to be seen as this week unfolds.
And those who are being tested, are they sent to go back home? How's the procedure on that?
Depends on the situation. We have very few patients in the hospital that have been tested. Most of the tests have come from patients who have called 6-8 nurse and been screened or been screened by their physicians, have been sent to our testing site. We've swabbed them and sent their tests away. For the most part, those people are told to go home and self-isolate. If they have symptoms that require hospitalization, of course they're coming to the hospital. But the vast majority of people are going home to self-isolate.
And how are you protecting hospital staff who are around these patients?
Well, there are very few patients, and so those who are in, as I said earlier, we're cohorting those patients together, so a smaller group of staff are caring for them throughout the day. Those staff members have personal protective equipment. We're trying to preserve what we have so that the people who are actively caring for these patients can have it. N95 masks, gowns, face shields, the full complement of personal protective equipment. We're not down to zero. We're nowhere near zero. We're trying to be sure that we're careful with our use of it, because we can go through the supplies of this disposable PPE very rapidly if we're not careful. So we're conserving it just for those people who are caring for the patients who are either confirmed diagnosed with COVID-19 or suspected. Sir.
How long will you be holding meetings like this one where you're in person with outsiders from the hospital?
I wish I knew. We'll be having these daily briefings Monday through Friday as long as they're necessary. Clearly, we've been asked to limit gatherings to fewer than 10 people. We don't have 10 people here now, and we're out in the open with pretty decent social distancing. So we're going to be careful about that. It's not our intention to hold large gatherings in enclosed spaces at any point, but it is important, I think, that we tell the community what's going on. We're trying to be reassuring that the hospital has the capacity, our medical community has the capacity to care for the patients we have now, and substantially more. So we want people to know that we're ready and paying attention to what's going on.
We have a question on our Facebook Live. What about the asymptomatic people who are positive but don't know?
The question is, what about the asymptomatic people who are positive but don't know? We don't know. We're not testing asymptomatic people. Most places in the country are not, so we're not aware of how many people are out there carrying the virus but not exhibiting any symptoms or not enough to meet the criteria for testing. I think all of us suspect that there are many of those among us who are carriers and asymptomatic, but we have no way of knowing that. And as testing becomes more available, I still don't believe we'll be testing asymptomatic people, but we'll be testing people who have symptoms in greater numbers and with more rapid turnaround. So we should rapidly become more aware of how widespread the disease is, but we're just not quite at that point yet.
Do you have an update on those people who you announced were under investigation? Has the number stayed 3 to 4, or is there more people under investigation?
There are more under investigation. Kit, what's the number on that is under investigation?
The testing, we've sent out several tests. As far as PUIs in-house, we only have one.
Just the one who's confirmed positive.
Right, just one confirmed positive.
Dr. Wilson mentioned 3 or 4 persons under investigation. That number has grown a little bit. I don't know exactly what the number is at the moment. I know, as I said earlier, we've got a total of 14 patients in those cohorts in the specially assigned areas of the hospital. I don't think all of those people meet the criteria for being PUIs, so it's somewhere between the 4 that Dr. Wilson said earlier and 14, and we'll have a better number on that for you tomorrow. Okay?
Anything else would you like to say?
I think I've covered my points, unless you all have questions. Any more Facebook Live questions? Yes, sir. Go ahead.
On Friday, Ector County came out that they've only taken 15 samples. And I was wondering what has given Midland more capability to do testing? And is there any outreach to Ector County to help them up their testing capability?
Well, I think everybody's got their own situation. I don't know how many people have needed testing in Ector County. We've tested quite a few more because we've been at it for a little while. We've promoted this among our medical community. We've encouraged the use of 6-8 Nurse, and many of the patients we've tested have been screened through 6-8 Nurse and sent to the testing site. So I really can't comment on their situation. We certainly are in contact with them, and we'll try to talk with them this week and see if there's anything we can do that helps. But neither Ector County nor Midland County is actually testing here. All of us have to take the swabs, package them, and send them away to a remote site. So how many we've tested, it's really much more important to know how many results we have, and we're hoping those numbers will grow over the next few days.
And just one more. I guess, you said you're 41% capacity. You have plenty of respirators at this point.
Right.
That could change very
Sure.
rapidly. And I guess, are the hospital's triage protocols being discussed in connection to the coronavirus yet?
The hospital's triage protocols. Well, we're actively managing patients as they come. We've funneled everybody through the one entrance. We've got fewer patients coming to us now to the emergency department than we're accustomed to. Triage protocols, I'm not sure I'm not sure what to say about that. Kit, do you have anything you'd like to?
Yes, we are doing our advanced screenings through the emergency department, funneling visitors through there. So we are triaging every patient that comes, every person who comes through the doors. As far as hospital operations, is that what you're asking?
Oh, I just, in other countries, hospitals have been overwhelmed, and triage has to be implemented as it's correct.
Yeah, I can address. Okay, I didn't completely understand where you're going with the question. Yeah, what you're talking about is the process of screening mass quantities of people who would be coming forward to the hospital. And we are talking about how best to do that should that happen. We're a long way from that point. Our facilities are nowhere near overwhelmed today, but we have the beginnings of contingency discussions that have been going on over the past week. Will continue this week. We'll have some ideas about what expanding our capacity might look like, but we're not really close to needing to do that today.
Just to confirm, you said 14 patients are in those cohorts,
Yes.
but a little over 3 to 4 are being screened as PUIs, so not quite 14 are PUIs?
We don't believe that all the 14 should be considered PUIs, and we'll firm up the PUI definition and give you better information about that tomorrow. I didn't have those numbers when I came here today. I know that Dr. Wilson had publicly stated we had 3 or 4 last week, And those 3 or 4, since we have so few results back, that's still valid, but there are a few more, I believe, than that, and we'll get you an actual number tomorrow.
And why do you think the medical system has been so flooded with people wanting to be tested for COVID-19, and it's taking a while for those results to come back? Can you just explain to us why that is and the process is?
Why the delay in testing results? Well, I don't know for certain. I can speculate. The labs are overwhelmed. We've got state labs that had very small capacity early on and were very slow to turn around the tests. We've had a variety of different commercial labs. The first one that we were using, we sent several tests to them and they quickly became overwhelmed and told us to stop sending tests. We've moved to a second commercial lab, which we understand has enough capacity, but they've also been slow to turn around results. So this is all new for everybody. They're still getting their processes going to turn these things around fast. I'm expecting that we will get a flood of results here in the next few days because we've had now greater delay than we expected from virtually all the tests that we've sent out. We've expected 48 hours or so, and we haven't achieved that yet, but I'm expecting they're all going to come break loose here very shortly.
Just from looking at other countries and how COVID's affected them, it tends to be this week, doctors are anticipating it will get bad here. Do you think that's going to be the case? Why or why not?
I don't have a way of knowing that, and I don't think anybody does. There's a lot of speculation. You can read any number of predictions. We are processing, at my last count, 4 different modeling tools that have been provided by various academic centers and trying to reach some kind of consensus internally about what the likely ramp-up period for the disease is so that we can see what's a predictable peak. How are we positioned to care for that? Do we need more capacity? We're not quite there yet, and there's not a really clear consensus on what the right model is. I read some speculation this morning that warmer climates seem to have slowed the progression of the disease, so it might be different in New York than it is here. There's really not a lot of clarity on that just yet, so we really don't know.
How's morale among staff?
Morale's pretty good. People are concerned. They're anxious, as you know. If you walk around the hospital, you'll see that we have a number of people wearing masks. Some that they brought themselves, some that are homemade. Those are not necessarily indicated by good infection control practice, but people are doing that because they want to be as cautious as they can be, and we're respecting that. We're allowing people to do it. We're asking them not to take masks from our limited supply, but if they have their own, if they want to make one at home, if they want to wear a scarf, there's any number of ways that would be acceptable. We're trying to respect that. So there's a good deal of anxiety, but very good morale. People are stepping up to do the work they need to do. We're reassigning people from the operating rooms and other areas that don't have any work right now because we've curtailed our procedures. So we're doing some retraining and reassigning of people outside their areas of comfort where they can contribute, and they're stepping up and doing that. So I'm very pleased with our staff's response and expect that to continue.
How are masks being dispersed?
Well, the masks that come from our supply are being used according to our policies. So if you need it, if you're caring for an isolated patient, you're going to have access to an N95 respirator. But we're asking people to reuse those, to carefully take care of them. Face masks are the same way. We have other types of masks that are indicated in other types of patient care, and once again, we're trying to carefully control those within our infection control policies and asking people not to use them outside those policies just to make themselves feel more comfortable.
We have a Facebook comment with the spring air and all the things blooming. So many have some of the same symptoms, but it's hoping it's just allergies and sinuses. Can we address the differences between these symptoms versus allergies?
Yes, we can. Although I'm not a clinical person and you're going to get outside my expertise pretty rapidly, the question is, can we talk about the difference between seasonal allergy symptoms and COVID-19 suspicions? I've had seasonal allergies all my life, so I'm very accustomed to this. I was fighting with them last week. Seasonal allergies are occurring in your head for the most part, in your sinuses, drainage, etc., sneezing and coughing. The symptoms of COVID are more lower respiratory symptoms. pain, shortness of breath in the lungs. Fever is a big one. We rarely have fever with seasonal allergies. Fever is a component of COVID-19 suspicion. And then, of course, there's exposure. If you've been exposed to a known positive patient, if you've been to one of the very large number of countries that are now on the level 3 risk list, if you've been on a cruise, those are also indicators that what might otherwise look like the normal seasonal flu is really suspicious for COVID. So seasonal allergies really are pretty dramatically different. They don't include the lower respiratory tract, the shortness of breath, and the fever that go along with this disease. Did I miss anything? Is that good? Okay. Good to have a clinical expert in the background.
Any other questions before we wrap up? No. Thank you so much.
All right. Thank you all very much for being here.